We are having 4 pages, okay? Started your 2 minutes time.
Okay, ma'am. Okay, ma'am. Next slide.
No. This is not the.
Madam.
No. This is
Yeah.
actually. Next point, next slide.
Okay, ma'am.
Started 10 minutes time.
Hi, I'm Dr. Reshma, one of the doctors in the early pregnancy clinic today. May I confirm your name and age?
Yes, doctor, I'm June. I'm 25-year-old.
Is it okay if I call you June?
Oh, yeah?
June, are you in pain or something now?
Yeah, doctor, I'm having severe pain in my lower tummy. And,
Can
it's
give you
not
some
getting
pain
relieved.
medication.
Yeah, thank you for that.
Do you have any allergies to any drugs?
No.
Okay, then I'll ask my nurse to give you some medication. How are you feeling now?
Yeah, better off.
June, is it okay if I ask you some quick questions for a better understanding? Then we will reach a safe and mutually agreeable plan.
Yeah, it's okay, doctor. Go ahead.
June, can you tell me more about your pain?
Um, yeah, doctor, since last 2 days, I have noticed that the pain is there. Initially, it was not that bad, but today morning it was so severe. I visited a GP in the emergency, and then he said, no, I just need to see you on a priority basis. That's the reason I'm here.
Oh, so sorry to hear that, June. June, can you score the pain for me? For 0 being the lowest and 10 being
It's
the
very
highest?
severe. It's very severe, doctor. I just can't do anything. It's very severe.
Okay, June, is there any factor which relieves your pain or which increases your pain?
No, the pain is sharp shooting in my lower tummy.
Okay, do you feel any dizziness or any fainting episode?
No,
Okay, are you feeling any shoulder tip pain?
no.
Okay, can you tell me regarding your pregnancy? Is it a planned pregnancy?
No, doctor. Actually, I'm not planning any pregnancy as of now.
Okay, I understand. What about your periods? Is it regular?
No, doctor. My periods are pretty regular. Actually, my last period was 5 weeks back.
Oh, okay. Sorry, June, to ask some intrusive questions. Are you in a stable relationship?
As of now, I am in a stable relationship. I'm with John since last year, and we are happy.
Okay. Do you have any history of sexually shared infections in the past?
Yeah, actually, the previous boyfriend which I had at the age of 2021, he had been treated, and even I had been treated at that time, and that's the reason I broke up with him.
Okay, I understand. Were you using any birth control measures?
I was not using, the John was using condom.
Okay. Have you been pregnant before?
Never, doctor, I told you I'm not keen to get pregnant.
Okay. Do you see your GP for any other concern?
No,
Okay. Any history of surgery on your tummy or down below?
no,
Any family history of concern?
no,
Okay. May I know your weight to height ratio?
it's normal.
Okay. What is your blood group?
I think A positive.
Do you have any reservations for blood transfusion?
No.
Okay. What do you do for a living?
As of now, I'm going to a grocery store. I'm a manager over there.
Okay. How is your support at home?
Yeah, I stay with John, so both of us are very supportive to each other.
Okay. Sorry, June, to ask some personal questions. Do you smoke or drink alcohol?
No, I don't smoke, but occasionally I do drink alcohol.
Okay. How are you feeling for the past few weeks? Are you in a low mood or depression?
Oh, doctor.
Okay. June, if you thank you for all this information. If you allow me, I would like to examine you in presence of the chaperone. My nurse will take your observations, and I would like to examine your tummy and down below. Is that okay for you?
Okay.
Also, June, I would like to do some blood test and a scan for you. As your pregnancy test came as positive, I would like to see the pregnancy hormone level in your blood, and
Hmm.
also to see the full blood count and a sample for a group and save. And I want to get a scan done, and that will be done from down below. Is it okay for you?
Okay.
Thank you, June, for all the cooperation. And we found that you are pregnant. Your pregnancy test came as positive. That means you're pregnant. But from your history and examination, I suspect that there can be some problem with your pregnancy. So some amount of pain is normal in some women with early pregnancy. But with this much symptoms, and from your history, I see that you had a history of sexually shared infection. So I suspect a pregnancy which is formed outside your womb. We call it as ectopic pregnancy. Have you heard something about that?
Okay. Yeah, I heard about it, doctor. Okay. So
Do you,
now
do you
what,
want
doctor?
okay? Do you want anybody with you while I'm discussing the condition?
It's okay, doctor. Just explain me what next.
Okay.
How you
This
gonna
ectopic
manage me now?
June, your management will be done by a team of doctors, including my consultant, the scan doctor, and the lab doctor, and a specialist nurse will be there to support you. And now, as I already told, we are going to do a scan and to do some blood test. And if it comes to be an ectopic pregnancy in the scan, and usually, generally, the ectopic pregnancy, the most commonly, it will be in the tube because normally the pregnancy is formed in the tube and it will be transferred to the womb normally. But in your case, maybe because of the previous pelvic infections and in some patients who smokes, in all that cases, this pregnancy formed in the tube will be retained there. And I can show you in a drawing. This is the womb and these are the egg baskets and these are the tubes. And if the pregnancy is formed in the tube, there is a chance that the tube can stretch as the pregnancy grows. There is not much space in the tube as that of the cavity of the womb. So when the pregnancy grows, there is a chance that the tube can stretch and it can rupture. And if that happens, there can be massive hemorrhage. And sorry to say that it can be uh, a problem for your life.
Oh
Am I
my
clear
God.
so far?
Oh my God. Okay.
Don't worry, don't worry, June. We are here to help you and support you. We will take all the necessary arrangements. And the management generally we manage this ectopic pregnancy in different ways. We can have expectant management, that is, we will just wait and watch. And there are some medications which we can give you. And the other option is surgical management. But in your case, as you're having severe pain, we cannot go for the expectant management or the medical management. We may have to go for the surgical management.
Okay. So what are the surgical options I do have, doctor?
Surgery options are either we can go for an open surgery or a keyhole surgery. And we will also, by the time, we will also monitor your observations like your pulse rate, your blood pressure, to get any clue about the rupture of the tube. And in the keyhole, if everything is okay, we can go for the keyhole surgery. In the keyhole surgery, there are two options. One thing is the removal of the tube. The affected tube can be removed. And another option is we can remove the pregnancy, retaining the tube. That will depends on different factors. Like if your other tube is normal, we can remove the affected tube so that we can ensure the future fertility, future chance of pregnancy. So other option is if we found that the other tube is also affected in some way, then we will try to remove the pregnancy only and we will retain the tube. Am I clear so far?
Okay, doctor. I am not that keen. And don't you think there is any medical medicines which will treat, if at all, it's not a ruptured one? Is there any
We
non-surgical
have got,
option?
yes, non-surgical options are there, and that we will decide after the scan and the pregnancy hormone level. After we get these two, that is, if the pregnancy hormone level is less than 5,000, and if the size of this uh, mass in the scan is less than 35 millimeter, we can go for medical management. But for that, you should not have this much pain. As you're having severe pain, as you said earlier, it will be better to go for a surgical management. Am I clear so far?
Okay.
Do you have any other concerns?
Will it affect my future fertility, doctor?
Future pregnancies, you can, if one of the tubes and ovary is normal, you can get pregnant without any doubt. But the problem is that if in future pregnancies there is a chance of that also getting into an ectopic pregnancy. So I will recommend you to go to the midwife early in your next pregnancy whenever the pregnancy test is positive, and we may need to get an early scan done to make sure that the pregnancy is inside the womb. Is it okay?
Okay. Okay.
Okay,
Yeah.
even if going for the surgical management, there are some complications which every surgery can have. Some problem with the sleep medications and some chance of injury to the surrounding structures. All these are there. And after the surgery, according to the surgery, we will follow you up with the pregnancy hormone. As if we are removing only the pregnancy, there is a chance that some retention of the pregnancy tissue there. So we will follow you up with the pregnancy hormone weekly till it become negative. And if we are removing the tube, we can do a pregnancy test after 3 weeks. Is that okay?
Okay.
Okay, so if you want, I can discuss with your partner or your family members. And I will also inform my consultant. He will see you in a moment. And if you have any other concerns, I am here to help you. Okay,
Thank
June.
you. Yeah, thank you.
Thank you. Thank you, June.
30-second extra. Okay, that's it. Well done. Very well done. Anybody would like to give a feedback to her? Critical feedback is very important to pass the exam. Anybody? No. Okay.
Ma'am, it was a very good presentation. She did very well. The only thing which I noticed that when she was talking about methotrexate, she I think forgot about the presence of fetal heart. If it is present, then also we will not give methotrexate. Otherwise, everything is very well done.
Yes,
Okay.
madam. Okay.
Yeah. Okay. So there are only 2-3 points which I had noticed. Mental history. Do you think mental history is important in this task? Only relevant history we have to take. What is the role of mental history? Why you asked mental history? Justify, Dr. Reshma. Rest of the history, yes, very relevant. Okay. Rather, you went too much in detail about the pain. Okay. So bowel bladder history also you can ask.
Yes,
But
madam.
why mental history? There isn't any relevance of mental history in this task.
Okay.
Do you think so? Or is it going to change your management?
No, no,
And
no.
then not generally early pregnancy, if it is early pregnancy, patient is behaving abnormally, then definitely ask. I'm not totally against not asking the mental history, but the patient is behaving or patient is insisting on something, then you definitely ask. Okay, take it as a clue and just ask her why you are doing, or means why you are insisting, why you are doing so. Okay. So Then you ask, but here the patient was stable, patient was not having any issue. Okay, it's a straightforward task, so do not complicate it. Okay, your history took almost 4 minutes 45 seconds. So those 2-3 points could have been, you could have able to finish the task within that 10 minutes. Okay, that is one thing. Team of doctor. What do you mean by team of doctor? You just need to involve your consultant here. The consultant is going to manage. Team of doctor, many a times it points out to the MDT. So avoid MDT using MDT. So your care will be under consultant led care. Consultant care. You will be managed in a consultant care. Okay. She will not be managed by GP or anybody else. So she will be managed by a consultant. Anyway, the people will always be involved. So that MDT, don't show MDT in all the cases. So yes, you will be reviewed by anesthetist, you will be reviewed by the anesthetist, and my consultant will be consultant will be managing you. So that one point. Okay, team of doctor, no. Repeated investigation twice, that is another issue why you had lost a track of few seconds. So avoid repetition of sentences. Crystal clear. You know your flow was very good, but I don't know why you repeated it. Okay. When you mentioned that since you had a infection, that is the reason you are having this ectopic pregnancy. So that is a RCOG suggests that is a judgmental way of pointing out. Judgmental way, because you are getting judgmental that I had STI in the past. So if you want to tell this, okay, so ectopic pregnancy is associated with various risk factors. The risk factor associated with ectopic pregnancy are any tubal surgery, any tubal sticky adhesions or tubal tissue damage because of the infection, intrauterine contraceptive device, and smoking. So these are the major reason why ectopic pregnancy happens. Sometimes it may happen without any reason. So you had told her that why it has been happened in her case, but that you do not need to pinpoint out that since you had an infection, you had this ectopic pregnancy. So that is a judgmental way of judgmental way of communication. If it is, if the by any chance you are going example in UK, they will not like this kind of thing. They will not like. In India, you will pass definitely. In Indian scenario, yes, there are very good chances that you will pass with this kind of sentences also, but see to it that you will involve third party. Okay.
Okay.
And the lastly, hemorrhage was a jargon which you had used, that there will be there will be hemorrhage if it will grow and burst. Okay, so that hemorrhage avoid. Non-surgical option, I wanted to know how you are going to manage me. Okay, even though she is not a suitable, here you don't know. Here do you have any idea, because she's stable. If she's stable, abdominal tenderness is there, but we do not know whether it is just a pain because of rupture, or it's just a pain because of that ectopic pregnancy which is giving rise to a collicutubal spasm. We do not know here. Okay, we do not know. So if I am asking you about the medical line of management, then yes, you just need to tell me, yes, we do have an option of medical line of management in the form of, then you have to explain me how you are going to manage me medically.
Okay.
Don't say that no, it is not suitable option in your case.
Okay.
Yes, if you fit into the, just tell her, even if you do not need to tell that the beta ICG should be less than 3500, the sac size should be okay. So if you fit into the criteria, we will offer you injectable methotrexate. That is what I wanted to know. Okay, so the options will be that injections will be there, which is a single dose. Yes, side effects will be there. So 2-3 sentences about that. Do not say that no, it is not suitable. You do not have any investigation, you do not have anything, but you know that okay, that means she wanted to know.
Okay.
That way you are
Madam,
going to. Yes.
Madam, in the guideline, it is given like any significant pain, it is not suitable for medical management.
Yes, any significant pain, it is not suitable for. But if I am asking you, that has been mentioned in the role player's instruction.
Okay. Okay.
Okay, so if you are if severe pain, basically we are just worried about rupture. Okay, it's if it is ruptured. If it is unruptured, no free fluid, only ultrasonographic picture, only means beta acidity within limit. So we have to evaluate her. You had advised her all investigation. You have to arrange it. If you fit into the, don't say that okay, you are not fit into. If you fit into the criteria, and if you want to say after that you can say that this sentence. After that you can say this sentence. But here I wanted to know about medical line of management. Yes, the medical line of management is an option when there but there are certain criteria which we need to fulfill. The medicines, that is injectable methotrexate, which is a single dose, need to be given. Then beta hcg will be done on day 2, day 4 and day 7 to see the fall in beta hcg. But in few means there are numbers, 7% you may require surgery, in 15% you may require repeat injections, okay, because the beta hcg hormone will not fall significantly. And I'm really afraid this will not be a suitable option in your case. That way also you can explain her. Here you are telling her, but you are addressing her concern. You are giving her information regarding medical line of management. And at the end, you can say here, I am afraid it may not be an option in your case because you are having severe pain in your lower tummy, and we need to see the values of beta hcg and ultrasonography. Okay.
Okay.
So this way is the answer. So introduction, situational awareness, aim, agenda, concerns, what's wrong, what is ectopic pregnancy, history, open question about pain and bleeding, LMP, previous cycles, regular, irregular, severity of pain, you asked, shoulder tip pain, fainting attack, you asked, bowel bladder habits, I think you have forgotten, but it's okay, but one need to ask, okay. Sexual history, you asked, history of STI, contraception, you asked, mere, you didn't ask, but it's okay. Previous partner, you asked, obstetric history, future obstetric history, you asked, surgical, medicine, allergy, you missed it. Hmm? I'm allergic to penicillin. Huh?
I asked in the beginning when she has pain.
Okay, okay. In the beginning only. Oh, yeah. So I was not at that time in the thought process. Okay, yes, you asked me. Blood group, BMI, JOA, smoking, alcohol, you asked. And you asked support. How far do you stay? If it is an unruptured pregnancy, ectopic pregnancy, then you can just ask her how far do you stay from the hospital, and is there someone to accompany you? Okay. Then explain her suspected. It is suspected diagnosis. It is not a complete confirmed diagnosis. So looking at your scenario, I am suspecting ectopic pregnancy. Have you heard about it? You had asked me. BBN, you had drawn very nicely. You had explained me how frequently it does occur. 1 in 100 cases. Why it happen? Infection, smoking, IUCD, surgery on the tubes, or lower tummy. Okay. So these are the reason. And you rightly mentioned that it will not accommodate the growing fetus, and it may burst. It may bleed torrentially, and then that will be a life-threatening if thing. Okay, so we need to start you by offering you clinical examination. Okay, so here I had offered her clinical examination. Then urine pregnancy test has been already done by the GP. Baseline blood investigation, CBC, urine, a baseline beta hcg, transvaginal scan to confirm the finding. Okay, for the confirmation. Three options. So you do have three options. One is wait and watch. If the pregnancy hormones will be falling and no symptoms, this will be a suitable option. Less, it will not be a suitable option in her case. Medical or surgical options. So medical options and surgical options. Okay, so I am just explaining her here. Okay, so in medical option, methotrexate is an injection which prevent these pregnancy tissues to grow further. A single dose according to your weight. Repeat beta hcg on day 4 and day 7, and see the fall. If the fall is more than 15%, okay, if the fall in more will be done once a week, 15%, if the fall will be more than 15%, then 15%, you will be observed. Okay, you will be observed. If fall is not significant, 15% will need second dose and 7% may need a surgical management. Uh, but we need to do certain investigation before offering this injection, as it may affect your liver function test. Avoid alcohol. Side effects are nausea, vomiting, sometimes rashes. Follow-up is must. Okay, so you need to have a follow-up. Avoid exposure to sunlight, avoid alcohol. It doesn't affect ovaries, means it will not affect your ovaries to produce eggs, and it will not affect your future fertility and future pregnancy. Okay, so this is an option but not a suitable option in her case because she is having a pain. The alternative option in her case will be a keyhole surgery or open surgery. So it's a surgical procedure associated with the risk of the surgery, risk of the anesthesia. uh, if the expertise will be there, the keyhole surgery is an best option. Early recovery, early discharge, she can go home early. Either salpingectomy, that means removal of the tube, or giving a scar on the tube if the other tube will be abnormal. Okay, so depending upon the other tube, the decision will be taken. Yes, even after the removal of the tube, the chances of so recurrence is always there when in subsequent pregnancy, and that for that we will definitely follow you up in the next pregnancy with an early ultrasonography, and report us early once once you will get pregnant in the future. Okay, now here I had just cut short these pros and cons, but you have to explain pros and cons of both the option. So surgical option, yes, it's a good option. Mm, risk, it will treat the ectopic pregnancy completely, but the risk of laparoscopy, risk of anesthesia will be there, injury to the, since laparoscopy sometimes is a blind procedure, there might be chances of injury to the bladder, any blood vessels, or bowel. That is one thing. Sometimes it may not get identified at that time. You may present afterwards. Once you have been discharged, you need to follow up if there are any untoward signs, and beta HCG or urine pregnancy test, depending upon the type of procedure what you have done, you had rightly mentioned. Okay. Discuss pros and cons. Arrange the blood. Now since we have discussed all these options with her, so now I will just take a leave from you. I will arrange your blood investigations and arrange transvaginal ultrasonography. If you are, since you are having a very excruciating pain, I will offer you examination, inform my consultant, document your care, and write back to GP. Since the GP letter is there, do not forget to involve your GP. Okay, and support until family member comes. Means I will offer you some support till someone comes from your home. Okay, specific PIL is very important. Specific support group is very important. So PIL about ectopic pregnancy. And support group is the ectopic pregnancy trust. They expect this much from you people because these are the more common topic. This will come here and there. So this most common topic, you need to know the bleeding in early pregnancy is one PIL, and support group of all early pregnancy module you need to know very thoroughly. Okay, so take comprehensive focused history, onset of pain, symptoms of rupture, dizziness, shoulder tip pain, fainting, history of chlamydia, tracheomatosis, treatment, LMP, and cycles. Social factor, you asked, offered me examination, initiate appropriate investigation, clear pass in information gathering. Communication, introduce self role, patient explain the suspected diagnosis and rationale for investigation, discuss the treatment option, medical versus surgical, various steps of surgical management, pros and cons, provide information at the reasonable pace and such a manner that the patient comprehends, encourage answers or question, obtain consent for surgery if surgery, even means yes, we need to say this sentence. Okay, we were missing out. Okay, so one need to sign a consent. If surgical treatment is the chosen option, communication with, these are communication with patient. Okay, so you had passed in this the module also. Patient safety, explain the risk of rupture and hemorrhage and need for IV line, IV fluids. Discuss the risk of medical management, including complications of methotrexate. Safe prescription having a certain allergy and contraindication to methotrexate. Okay. Applied clinical knowledge, actually they had mentioned so many criteria. So this is basically the guideline of the nice guideline of ectopic management, what they had mentioned here. Okay, so very nicely mentioned in applied clinical knowledge. Medical treatment, stable 1500 to 5000 USS, gestational sac less than 35 millimeter, no active fetal heartbeat. Methotrexate IM, then monitor SCG day 4, day 7. Decrease more than 15%, continue monitoring. Decrease less than 15%, TVS repeat in 32 to 75% of cases. TVS and repeat dose in 32 to 75% of the cases what they are quoting. I think 15 and 7% is the PIL figure what they had mentioned. I don't know from where this figure has been taken by the book. So this is from the book actually. Success rate is 65 to 95%. Very good success rate with methotrexate if you fits into the criteria. Okay, may need repeating SCG monitoring until it comes normal. Okay, surgery, laparoscopy, salpingectomy or salpingotomy. Salpingotomy if unruptured and tube will be preserved. Follow up with beta HCG, contralateral tube damage, salpingectomy. Salpingectomy if contralateral tube normal or tube ruptured. Contraception, avoid IUDs. Okay. Risk of recurrence 1 in 10%. That is what they are saying. NICE and RCOG Green Top guidelines is a basis for applied clinical knowledge. Okay. Very well presented, almost pass in all aspects. Few points here and there. Okay. Any question anybody having? No?